Good afternoon. Yes, this afternoon. It's really good to be here today, and I've heard a lot about Edge Hill, and as Barbara said, we've been working together for quite a few years, but this is my first visit to the university, so I'm really pleased to be here today. And in the next half an hour, I'm just going to share with you a bit about some of the work that we've been doing internationally to increase access to palliative care around the world. So I'm going to share with you some of the achievements and some of the challenges. I'll start off by looking at why we need to increase access to palliative care around the world. Sometimes when we're working in places like the UK, where access to palliative care, although we might not think it sometimes, is actually very good. And so why do we need to look at this in an international perspective? And what are some of the principles behind how we increase access and looking at the public health model for palliative care? Then I'll share with you some different examples. And I'm going to share examples from a global, international perspective, right down to the patient perspective. And obviously, in everything that we do, there are always challenges. So we'll look at some of those challenges as well. And as Barbara said, I'm quite open for questions afterwards. So the first question that we need to ask ourselves is, why is this an important question? Why do we need to increase access around the world to palliative care? Well, it's so children such as these were in Uganda, two little children who came to our daycare program. They're both HIV positive, they're both orphans, and both of them, their CD4 counts are very low and their life expectancy is very short. And so we need to make sure that access is available for them and for others that need palliative care, wherever they are in the world. It doesn't matter how old they are, where they're from, what colour they are, what religion they are, they should have access. Everyone should have access to palliative care. And palliative care is recognised now as a human right, access to pain management and access to palliative care. So how do we make that a reality, so that children like these two can have access to palliative care? Well, we know that the need is great. In 2010, over 8 million people died from cancer, and that's 38% more than 20 years ago. And we know, if we look at the statistics, that this is going to increase. And around the world, 15% of deaths are attributable to cancer. And in Uganda, where I've done a lot of work, many people don't actually present until it's too late. So for the majority of our patients, care is palliative care. To put it in perspective, Uganda has one cobalt radiotherapy machine. It's very old, so the length of time for treatment is long. And that one machine services the whole of Uganda, Sudan, Rwanda, Burundi, and the Democratic Republic of Congo. So we just have one machine. So even if you do go early for treatment, often palliative care is your only hope. So we know that there's a great need in terms of cancer deaths. We know that in sub-Saharan Africa, the rates are expected to grow exponentially in the next 50 years. And by 2020, they think that around 70% of new cases will be in the developing world. So how do we manage that? And how do we provide care for those people that need it? If we think about those needing palliative care at the end of life, and there's a very good atlas, the Global Atlas of Palliative Care at the End of Life, in 2011, they said that there were 54.6 million deaths, and 66% of those were due to non-communicable diseases. And so this whole area, and there's been a large thrust in the last few years around non-communicable diseases. And from the estimates in the Global Atlas, they reckon that over 29 million people died from diseases requiring palliative care. So how do we make that palliative care accessible to those who need it? And yes, a majority of them are adults, but there's still a significant number, 6% of those that need palliative care are children. And how do we provide palliative care for children in different parts of the world in a way that is accessible and affordable? So we know the numbers are large. Around the world, we need access to palliative care. There's been work done by Clark and Wright, David Clark, looking at mapping the provision of palliative care services. And on this map, if you look at the yellow, that's areas, this was in 2006, areas where there was no known palliative care activity at all. And even in 2006, there's quite a few yellow countries. If you look at the green ones, they're the countries where palliative care is well developed and well integrated. And you can see actually that the majority of the world is not green. And so this was back in 2006, looking at how we need to and where we need to develop palliative care. They've redone that mapping in 2011. Unfortunately, they changed the colours, so it's not quite so easy just to compare the maps. But again, we're looking for the bright green. And in this one, red is where there was no known activity. So there are still some countries where there are no known palliative care services. And there are very few, and UK is one of them, where palliative care is reaching integration and where access to services is relatively good. But what about for children? We've already looked at the Global Atlas that said around 6% of those that need end-of-life care are children. What's the situation for children? And in children, it's very different still, because the children's palliative care services are often lagging behind those for adults. So this is a similar mapping process. Again, we want the whole map to be dark green, because the dark green countries are where there is well-developed children's palliative care. And in the white countries, and you can see most of Africa, where I've done a lot of work, is still white. There are no known activities in palliative care for children. But if we put a map on top of that, on where are the most children dying, unfortunately, it will be in those countries where there's no services. So there's this big disparity between need and service provision. So what does all that mean? That's lots of different figures. Sometimes, like the Global Atlas, it's just looking at people who need care in the end-of-life period, which is usually the last 6 months to a year. What about those who have diseases that progress for longer than that, who need care for a much longer period of time? If you look at children's palliative care in the UK, children are in the palliative care services for many years. So the need is a lot wider, a lot broader than these figures actually suggest. So it doesn't actually show the actual situation. But what it does show, what all these figures show, is that there is a great need for palliative care around the world, and also that there are great gaps. So we need to push boundaries, we need to think outside the box, we need to try and extend access to palliative care. So how do we do this? And what are some of the principles behind that? Well, I've already mentioned the principle of palliative care being a human right. And it's interesting because once you get that human right aspect, it brings in a whole wider group of people who are interested in developing palliative care. We need to collaborate. We need to work together. We can't do this on our own. We can't even provide services on our own here in this area of the UK. So if we're going to increase access to palliative care, we need to do that together. We need to have a unified view. We need to be united in our approach. And it's interesting because if you actually sit down with a group of people working in palliative care from around the world, they might all have different definitions of what palliative care is. And if you add in the donors' definitions as well, we have to actually agree on what we're talking about in terms of palliative care. We need to be looking at strengthening leadership. We need leadership in all these countries, in all these places, to develop palliative care. And we need to be doing all this with a view of compassion and with our hearts and minds set on the philosophy and principles of palliative care. We also need to be confident in who we are. I'm a nurse. I'm proud of being a nurse. And I need to be confident in my abilities and my role as a nurse. So we need to be confident of who we are as individuals, as professionals, and as nurses, as we try to expand access to palliative care around the world. These are some of my colleagues who I work with in Uganda, and they are all nurses, and within Uganda, and in fact within the whole of the region, nurses have a key role to play in the development and implementation of palliative care. And we know here in the UK the role of the nurse specialists, the palliative care nurse consultants, and how very much it is a team working as a team effort. In many places in Uganda, we don't have enough doctors. There are only nurses. We don't have social workers in many places. So the nurses have this key role in developing palliative care. And they are able to move things forward. This is a graph. It's slightly dark, but it's the number of inhabitants per doctor. And you can just about make out in Africa, in the centre, there are 50,000 inhabitants to one doctor. Uganda, it's around 33,500 inhabitants to one doctor. So as much as we value and respect and work together with doctors, they're just not there. And so if we don't empower nurses, if we don't empower volunteers, if we don't empower carers and relatives of patients, then we're never going to be able to provide the care that we need to. So we need to be working collaboratively, and we need to be thinking outside of the box. I've been doing quite a bit of work in Namibia where we have community health workers who are illiterate providing a lot of the care. And people will say, well, you can't do that. Why not? If they're the people who are there, they're the people who need to be empowered to provide the care. And we as health professionals or social care professionals need to be working with them to empower and enable them. So this is the public health model for palliative care, which some of you may be familiar with, which very much forms the backbone of the work that we do in the development of palliative care in different countries. So it recognises the need for education. Education not just for health professionals, but for the media, for the public. It recognises the need for policy. We need overarching policy. In Uganda, if there's no policy, you'll not get any funding. So if before palliative care was in the policy, there was no way we would get any funding from the Ministry of Health. We got it in the policy, then it got in the action plan, and then eventually we get a bit of funding. So it's about working from the top down, but also from the bottom up. So making sure there are appropriate policies, making sure that there are medications available. In many countries around the world, you cannot get access to strong analgesics. When I first went to Uganda, I was out doing a clinic, and the strongest analgesic we had access to was paracetamol. There was nothing else stronger than that. So we need to make sure that in countries where the laws and regulations are prohibitive, that those laws and regulations get changed so that we can get access to strong analgesics. Again, when I first went to Uganda, if as a nurse, if I was carrying a bottle of oral morphine liquid solution to a patient, if the police stopped me, I could be arrested for carrying it. And so we had to work with the police, with the regulatory bodies. So now it's okay. Now we can get that oral morphine out and available. And obviously implementation is key. How do we implement palliative care in different settings, with different resources, in a culturally appropriate way? And then more recently, in a paper in The Lancet, this fifth pillar has been added, and that is of research, making sure that everything we do is evidence-based. And I'm sure we're all very much aware these days of the tightening resources. And we have to be able to show, don't we, that we are giving value for money, that we are giving good quality. And so we need to be looking at the evidence base for palliative care. So I'm just going to give you a few examples of some of the achievements, some of the different areas where we've been able to bring about change. The first one is the World Health Assembly. This year was a very key year for palliative care. For the first time ever, the World Health Assembly discussed and passed a resolution on palliative care. So that was in May of this year. And it was interesting because this resolution had to be sponsored by one country, and then all the other countries bought into it. And Panama, a small country in the middle of Central America, supported this and really got this resolution through the World Health Assembly. And it's about strengthening palliative care as a component of integrated treatment throughout the life course. And it's such a key thing for people working internationally. As I said, it's the first time ever that palliative care has been discussed by the World Health Assembly. It's really put together by all of the different international palliative care organisations, the Worldwide Hospice and Palliative Care Association, International Association of Hospice and Palliative Care, the UICC, the Union Against Cancer, etc. People collaborating and working together to really get palliative care on the agenda. So never before has there been such a global recognition for the need for palliative care and commitment to providing it. Once this resolution was passed in May. In 2 years' time, every country has to report back on what they have done in the development of palliative care since May this year. That's every country in the world. So this is our moment to try and go out there and say, you've got to report on this, we can help you. And how do we do that? How do we do that? There aren't enough of us to do it, but it is our opportunity. This is the time that we've been waiting for, because now palliative care is on the agenda. And interestingly, working in Africa, the Ebola is a big issue. And this is one of the things as a palliative care community we're also looking at, is how can we address the palliative care needs of patients with Ebola, but importantly the bereavement needs of family members. There's going to be a big need in West Africa, hopefully when the Ebola is more under control, for that palliative care input and for that bereavement support. So what about advocacy? And a bit about, just want to share some of our experience about how many children need palliative care. We were asked by the World Health Organization, how many children need palliative care around the world? And we thought that would be quite an easy thing to do, you know, just add up the numbers of children that need palliative care around the world. It was a challenge, and we worked with the UNICEF to do this, to try and provide some figures, because there were no figures. And, you know, politicians, policy people, they want figures. They want to know what difference is it going to make? How many people is it impacting? How many people are involved? And so we thought it was really important to try and do this. So we developed a study which was initially just in 3 countries, in Zimbabwe, Kenya, and South Africa. And initially the idea was to try and develop a robust methodology for actually understanding how many children in those countries need palliative care, and a methodology that we could use in other countries. And we also wanted to take the opportunity to, once we've identified need, to look at coverage and to try and see the gap in between, what is needed and what can be done. So we went through various different processes, utilising a lot of the literature and trying to work out which children needed palliative care. And that was a big challenge. We had great arguments with the World Health Organization around which children need palliative care, because a child might survive in the UK with a certain illness, but they won't in Uganda. So that means, how do we get that balance? And by saying a child needs palliative care, we're not then saying, but we're not going to do everything possible to help them as well. So there was great discussions with the World Health Organization. But we worked out various methodology of doing it. And in the UK, the study by Fraser et al. Suggests that 32 out of every 10,000 children need palliative care. In Kenya, it was 120, going up to 180 in Zimbabwe. So it was between 3 and 6 times as many children in those countries that need palliative care than here in the UK. So that has various different challenges for us, because the numbers are so big in Kenya and places, you're almost trying to narrow down the number of children that you'll see. Whereas in the UK, because the numbers are relatively small, you're trying to sometimes enlarge it to make your service viable. So very different challenges for us. But when we looked at what was actually being provided, in Kenya, less than 1% of those children have access to any form of palliative care. That went up to around 5% in Zimbabwe and South Africa. But still, that's 95% of the children who need access to palliative care in those countries who aren't getting it. And so we've been looking at what are the barriers to this and how can we try and improve that. So that's another example of how working together with organisations such as the World Health Organization, UNICEF, the International Children's Palliative Care Network, hopefully we've come up with a way of estimating need, which is now being utilised in India, Bangladesh and Eastern Europe, to try and get a feel of how it works in other countries. So trying to estimate need in a sample of high-income, low-income, middle-income countries, so that we can begin to get an idea as to how many children around the world need palliative care. Because that's our big advocacy tool for trying to get funding, trying to get services developed. Another area that has been very important within children is recently the WHO published new pain guidelines for children. Previously, we'd been working on the pain guidelines for children with cancer. They've now extended it out to include the treatment of children with persisting pain. And I mentioned earlier about extending barriers, pushing barriers, trying to look at other ways that we can increase access to palliative care. And it's not always about doing something new, but it might be about revisiting old things. These new guidelines, if you've seen them, they recommend various changes. One of them is key. It's a change from a 3-step analgesic ladder to a 2-step analgesic ladder. And one of the reasons for that is because there is a lack of evidence. So if you know your 3-step ladder for pain management, the middle step it uses medications such as codeine and tramadol that actually there isn't evidence for their use in children, or the evidence that is there is not good, or it suggests you shouldn't use it. So not only in some countries can you not get those medications, but there is no evidence. So one of the big challenges for us that has come out of these guidelines is that there is a desperate need for evidence in children's palliative care, in pain management particularly, and in the use of medications. I've also mentioned the fact that access to drugs, including opioids, is poor. It's patchy in some countries. There was a series done on Al Jazeera, the TV show, and there's one of them which is actually looking at somebody in the Ukraine, and he's talking about his experience. He's got cancer, he's dying from cancer, and he sleeps with a gun under his pillow so that when the pain gets too bad, he can shoot himself because there is no medication. There's nothing for him to take. And so for many people throughout the world, that is the reality. And here in the UK, we often talk about switching opioids and, which opioid is the best. For many people, they don't have that luxury. It's just, can we get access to medications? And that's particularly true for children. Many countries where they do have access to medications don't have access to pediatric formulations. And if you work in children, you know what it's like when you're kind of breaking a tablet, and particularly if it's a tablet that's got several drugs in it, you're not quite sure what sort of dose you're giving the child. So it's a big challenge for us. So there have been many gaps in research identified, and we're being encouraged to develop our research in children's palliative care. Obviously, education is key, and we need to look at how can we provide education in different formats. Picture at the top is actually training nurses in Uganda on palliative care. The picture at the bottom looks as if they're playing a game, and they are. That's in Serbia. That's training on children's palliative care. In Serbia, you don't tell anyone their diagnosis or their prognosis. You just don't do it. So trying to change that mindset, that not only should we be talking to adults about their prognosis, but we should be talking to children as well. So a lot of education is needed to bring about those changes in mindset. So in order to increase access, well, there's lots of different ways. I've just given various examples of work that's been done. These are core competencies for education in paediatric palliative care. That's the white paper from the European Association of Palliative Care. There's various online training programs. There's lots of different ways that you can provide education. And I think the key for us is that it needs to be a wide variety of different methods. We all know that people have different learning styles. Some people will work well remotely, others won't. Some people don't have access to the internet, or if they do, it takes half an hour for a page to open. So how can we make sure that we provide education in different formats? This is just an example in Serbia. You can see that they've got syringe drivers there. The EU funding provided syringe drivers for about 65 different places across Serbia. But nobody knew what a syringe driver was. They didn't know how to use them. They couldn't use them safely. And so there's some training very much gone into that. And we're very excited because I've just got 2 of them here. We've just published 4 books on palliative care in Serbian. First publications on palliative care in Serbian, to try and get information out to others. So education, information is really important. How we deliver palliative care, these are just different examples. This is, Barbara will probably recognize these people from hospice. They have a roadside clinic, so one afternoon every week the car just draws up outside, it's by a big tree, and the patients go and they wait there by the road. It's the best way of getting treatment, care out to the rural areas. So we need to think about our models. I did an evaluation of some models of palliative care in Kenya, and one of them was a clinic on the back of a camel, and literally the camel walked across the very dry desert area with the clinic on its, all the medications and stuff on its back. Different to what we do here, but appropriate for that context. Had a slight problem because the camel died, so then there was a big challenge to that clinic, but I understand they have a new camel. This is one of the new palliative care units in Serbia. So making sure that the way that we provide palliative care is appropriate for the context and the culture. And I think we've done quite a lot of work internationally looking at palliative care and how we provide it. The philosophy is the same. The philosophy and the principles are similar throughout the world, but how we do that is different. And there are many different examples. This is an example of a pediatric program, beacon centres where people can go in Uganda, Tanzania and South Africa for training. Because one of the challenges we have, if there's not many services, there's not many people trained who can actually provide that training. Working together, these are countries within Africa supporting each other to develop services, to integrate palliative care into the government systems. If it's integrated into the government systems, then it's more likely to be sustainable in the long term. And to work with link nurses. So this is at the National Referral Hospital where I work. We have a palliative care team, but on each of the wards we have trained link nurses in palliative care so that they can provide the majority of the services with us just seeing those with specialist needs. So it's around adapting and providing services in our areas. And then the last sort of area of achievement is that of patient care. And of course, this is what it's all about. We have to make things better. We should have access to palliative care, whoever we are, wherever we live, regardless of our illness, however old we are. This was a young chap. If you know your history of Uganda, in the north, people live in internally displaced camps for safety from the rebels. This was a young lad. He's got, and I can never say it, mycosis fungoides, lymphoma, and he was literally crying in pain in one of these camps. They brought him down to Kampala. We tried to give him chemotherapy, but we could only find in the country enough for 1.5 doses of chemo. So there wasn't much we could do for him, but we could manage his pain. And we took this photo of him, and he said, please show everybody that I'm smiling, and that although we don't have a lot here, you have made my life better. And I think to me that's the important thing, that we can be working at policy level, I can be working education, I can be working in all sorts of different things, but am I making a difference to individuals like him? So just finally, before I close, obviously there are challenges to increasing access. There are many different socio-cultural ones, and I've mentioned already about in Serbia you don't tell anyone that they're dying. In Uganda they have a very tight mourning period, and after that you don't talk about the person you've lost. So you've lost your child, you can talk about them for 3 days. After that, you're not supposed to talk about them because of the whole ancestors and traditional religions and things. So how do you provide bereavement services, palliative care in that environment when they're not actually supposed to talk about their child, but they're desperately grieving? So the sociocultural issues, government, legalistic and the national context, the service providers, many nurses, doctors see palliative care as a failure. So how do we educate them? And the service user level. People hear, well, those strong analgesics are addictive, we don't want to use them. So there are many different challenges that we come across. There are many complex needs of those needing palliative care. Lack of health and social professionals, lack of funds, lack of specific training, lack of recognition of our role as nurses, etc. I'm a nurse, I'm proud to be a nurse. When I first went to Uganda, if somebody called me a doctor, I corrected them and said I'm a nurse. I don't anymore because their attitude changes towards me because I'm a nurse, not a doctor. In Serbia, nursing education is secondary school level. You train as a nurse between the age of 14 and 17. You don't have anything above that. So nurses are way, way down the pecking order. Again, you have to be careful when you say you're a nurse, because their perception of a nurse is not somebody who's well educated, who is able to make their own decisions. How do we develop palliative care in that context when we're saying nurse-led services, but actually the nurses are still over here in terms of their progression? So many exciting challenges for us to work with. The high burden of disease. We had a doctor come from the States. He came for a week to the program I was working. He was a pediatrician. He said to me, the first morning he was really excited and looking forward to it. I saw him at lunchtime. He was in tears. I asked him why. He said he'd seen more children that morning who were dying than he'd seen in his previous 20 years of professional practice. So it's a completely different ballgame. The high burden of disease, the child-headed households. We have 10 and 11-year-olds looking after their younger children because all of their families have died and their siblings are sick. How do we provide care in those contexts? But one of the things my colleague Liz Gwither from South Africa says, we might be low in resources, but we are very resourceful. And I think that's one of the many things that I have learned through working internationally, is how do you look at things slightly different? How do we utilize what we've got? So in summary then, why do we increase access? We increase access so that children like those here at Malago Hospital can have access to palliative care. So that this is the ward where our office is based in Malago, 120 beds, but you can see the ones in the middle are not on beds. So there's usually about 160, 180 patients. 2 nurses on duty. How do we provide palliative care in that context? We can, but we need to think outside the box as to how we do it. So can we increase access to palliative care around the world? Using Obama, yes, we can. We can make a difference. We can increase palliative care. It might mean that we need to step out of our comfort zone. It might mean we need to do something different, and I guess that's what I did. I definitely stepped out of my comfort zone and went to live in Uganda, but I have learnt so much from that. So we need to think about other ways of increasing access. And I really like this quote: if you want something in your life you've never had, you'll have to do something you've never done. And I think that's in our work, in all of the work that we're doing, and I'm not just talking about internationally, but the work that we do here at the university, in the hospitals, we sometimes have to step out of our comfort zone to do that. Dame Cicely Saunders, or Robert Twycross, talking about Dame Cicely Saunders, said, "We too must not just talk the talk, but like her, we must walk the walk and stay the course and continue the task of changing the world." So I believe each one of us can make a difference. Small steps. In Uganda, we have a saying, if you think you're too small to make a difference, try going to bed with a mosquito, because you know you've been to bed with them. We can make a difference, each one of us, so that we can increase access to palliative care for those here, around where we live here, but also internationally and globally. Thank you.